Vlad, whenever you're ready, you can start, young man.
Good morning, everyone, to week 2 of our summer lecture series. Hope everyone is having a good day. Today, our first speaker will be Mr. Sagar, Mr. Sagar Singh from St. Louis Community College and Francis Howell North High School.
All right. I'll go ahead and share my screen. Hello, everyone, and welcome to week 2 of our summer lecture series. I'll be the first presentation today. My name is Sagar Singh, and I'm a student at the University of Health Sciences and Pharmacy in St. Louis, Missouri, and part of the early college program of St. Louis Community College. Today, I'll be presenting and showcasing a paper titled Endoscopic Extra-Articular Surgical Removal of Heterotopic Ossification of the Rectus Femoris Tendon in a Series of Athletes. Below listed are the respective authors as well as their affiliation. Now to give a little bit of background before getting more specifically into the paper, heterotopic ossification. This is a disease that occurs due to the tendons having a deposit of having a lot of calcific deposit. Now, calcific deposits are very common. However, the heterotopic ossification of the rectus femoris is a rare condition. And so that's partly the reason why I chose to showcase this paper in today's journal club, because there isn't much literature surrounding this disease. This study specifically, what they did was they took 9 athletes that had no improvement in their condition after the traditional treatment that is recommended, the traditional non-operative treatment that is recommended for heterotopic ossification. And they took these 9 athletes and they performed endoscopic procedures and did a study with. Now, specifically looking at the study methods of this paper, firstly, we need to know that the traditional treatment of heterotopic ossification is considered to simply be mainly non-operative treatment. So this includes just rest, hot and cold therapy, other forms of physical therapy, as well as shockwave therapy. So specifically within this study, they took those 9 male athletes with the condition of heterotopic ossification, the HORF, whose CT and MRI scans showed no improvement after a 6-month period of this non-operative treatment. The audio analog results for the study, specifically the SRP-VSA analog scale, to determine the statistical results. So more background regarding the actual procedure done in this study. What these surgeons did for the treatment was that they went in through 2 portal entries and they removed the calcified lesions and resected these lesions as well. Afterwards, these patients then received pain medications twice a day, such as naproxen, and they collected data regarding their health conditions over an interval of 1 week, 2 week, 1 month, 3 months, and 6 months annually, 2 years, to evaluate their reoccurrence of HORF. So afterwards, they performed a statistical analysis using this data. To simplify the statistical results, what we see in terms of the real world context is that there was a 90% chance of having a return to full activity, as well as no patient was presented with any sort of decrease in their clinical wellness. And only one patient had a reoccurrence of this issue, and the lesion that was present in this reoccurrence was smaller than the original lesion before the endoscopic procedure. So when we look at this from a bigger point of view, what we see is that traditionally only non-operative techniques have been encouraged in the treatment of calcific tendonitis and HORF. But the results of the study, despite some sample and setup flaws shown, the statistical results of this still show that despite some of these limitations, further controlled prospective studies should be able to try to correctly address and make a comparison between endoscopic techniques. Now, non-operative treatment should always be the first line of defense, but these techniques, these surgical techniques, should definitely be given more literature on them and more investigation on them, especially with the clinical results that they are producing. And this paper specifically encourages future studies to try to address this gap in literature surrounding the techniques to treat these diseases that may be unresponsive to non-operative traditional treatment that is encouraged. And below listed are my references as well as my academic affiliations. I'm open, I have the floor open for any sort of questioning, clarification, comments, etc.
Yeah. What would you say would be some limitations surrounding the study?
This paper definitely had a limited scope in how its study was set up. And the first things that pop up to mind is firstly the sample size of having 9 athletes. This is a sample size of 9 makes it really hard to produce statistically significant results. Some more limitations that we could see is that in the study, these patients, these 9 athletes in the study, they were also given pain medications such as naproxen. And this can obviously be a sort of confounding effect because these medications and other sort of confounding effects could also be responsible for the statistical results produced in the study. Another one is how the population was non-uniform, with a mix of some soccer players, some rugby players, and this could have been much more controlled. And that's part of the reason why in the overall discussion, this paper, it has limitations, but it does show that there's a gap in literature regarding endoscopic techniques, and it encourages further, more secure studies.
Thank you.
I'd also like to ask a question, if that's okay.
Yeah, go ahead.
So on the topic of heterotopic ossification, what would you say is like one of the biggest leading causes of heterotopic ossification?
So heterotopic ossification is inherently when bone tissue gets stuck in, gets sort of mixed along with soft tissue. And so I would say that mainly in terms of like physical man-made causes that mainly cause this disease, I would say it would be after some sort of traumatic injury, as well as any sort of major orthopedic or joint-related surgery.
Well, thank you for that talk. That was very good. The question I have is, obviously, they've discussed in the literature as well as procedural-wise, dissecting some parts of the ligament tendon, if there's calcification, congestion, seen like within jumper's knee, things like that. I recall, doing that overseas. in the operating theater that they would do the dissection of the patella tendon. But the question is, if they dissected the tendon ligament, how do they know when they dissected enough where it causes limitations on the tendon? Did they discuss any of that? And what this population, did they say they're going to follow up with them or long-term?
This study only had a span of around 2 years, so this is another limitation of the study where it isn't they aren't followed through for a longer period of time. And those techniques were also not very well specified within the paper as well.
Yeah, because I definitely could see the benefit of removing the calcification that has not been addressed with shock therapy or with some type of intervention. And this occurs with tendonitis and bursitis, where the tissue therefore becomes calcified over. Obviously, in professional sports athletes, they're willing to go to these lengths under the knife to remedy the problem and therefore to continue playing at that quality level. So it's kind of unique to see that this population occurred, let alone how much, I'm assuming this was done in South America and Brazil?
Yes, it was in Argentina.
In Argentina. Yeah, they play high level soccer and rugby in Brazil and Argentina up until quite an older age. So did they take a look at the age? What were the ages, the standardization of ages?
The mean age of each of these players
20.
was 32 years old.
So if we look at that, that's kind of on the higher end of their, playing careers. We even seen that with, everyone's worried about, Tom Brady, things like that. So that also needs to be taken into consideration that this calcification is maybe an itis that has become calcified over for a long period of time. So you have to take that into consideration also. But again, I'm not saying these players played quite well professionally to quite a long time overseas compared to the United States. So that's something to take into consideration. But otherwise, thank you for the paper. It was very good.
Yes, sir. Thank you.
Thank you, Sagar, for your presentation. That was very good. Mr. Borna Golbarg from California State University, Northridge.
Alrighty, let me share screen now. Just making sure, can you guys see my screen?
Yes.
Beautiful.
Yes,
alrighty. Hello, everyone. My name is Borna Golbarg. I am a recent graduate from California State University of Northridge, majoring in kinesiology, exercise science. And today I will be presenting a case study done on the treatment of post-traumatic myositis ossificans of the anterior thigh with the extracorporeal shock wave. Slide. All right, so before I get into the patient's background, let's talk about what myositis ossificans and extracorporeal shockwave therapy are. MO, which is what I'll be referring to, myositis ossificans throughout this presentation, is when a bone forms inside your muscle or other soft tissue. Usually with MO, it develops after a traumatic injury or repetitive microinjuries. It often affects large muscles such as your arms and legs, but it could also occur in tendons and joints and ligaments as well. It is important to note that post-traumatic MO occurs in approximately 20% of large hematomas, and it is non-inheritable. Moving on to extracorporeal shockwave therapy, which is a radial shockwave therapy that provides a mechanical wave in a narrow and focused pattern that increases circulation and causes metabolic changes. And it essentially allows the injured area to heal properly by breaking down tissues and induces repairing and healing mechanisms. Now, in this study, we had a 20-year-old rugby player that sustained a severe contusion to the right quadriceps on the vastus lateralis after he made a severe collision with another player. He reported his issue 2 months after the initial trauma, reporting progressing pain during weight bearing, and significant decrease in his range of motion, not even being able to move his knee past 45 degrees angle as he reported. Immediately, the aim of this case was to store his range of motion and strength in the right quadriceps so the athlete could make a full return to sport and measure the effectiveness of the ESWT, which is the device that we're going to be utilizing in this research, and as well as comparing literature values. Moving on to our next slide. So we had the patient go through 2 weeks of treatment and 3 sessions of ESWT while progressively increasing the shock wave range each session. 3 sessions of unsupervised exercise programs was also administered. The exercise programs included active and passive range of motion exercises and strength and balancing exercises. The collection was done via the analysis of routinely collected qualitative and quantitative data, and consultation and observation was also made. Now, let's go over the results, which actually is quite interesting. This is because the treatment began 10 weeks after the post-injury, and the patient actually started with 9 degrees range of motion. So initially, when he got hurt, he had 45 degrees, and at the start of the treatment, he was able to move his knee up to 90 degrees range of motion. At the end of the first session, he progressed to 100 degrees with mild pain at night, and in the second session, he increased his range of motion to 115 degrees with no pain at night. And in the last session, he gained full range of motion at 125 degrees, which is almost full gain of motion, my apologies for that, and no pain after the workout. The patient returned to specific training in week 13 and reported playing a 60-minute touch rugby game. In week 14, he gained full range of motion with equal muscle fatigue in both legs. And in week 17, he reported that he was playing touch rugby at full capacity and was at his pre-injury levels, both in the weight room and in the field. So let's discuss why this research is being explored and why such non-traditional route of treatment for MO patients are usually not advised. So the paper that we're going through is going to explore this, the new device, and usually the treatment that's administered for MO patients are non-invasive passive treatment rounds such as rise, stretching, pain-free range of motion exercises, and some have also utilized non-steroidal and anti-inflammatory for hip arthroplasty MO, which has been proven effective, but it has never been studied in post-traumatic contusions. Now, these non-invasive procedures have remained the same for 20 years, and in the world of sport, timing is really key, and how quickly you return to play is essential for an athlete. Therefore, expediting the healing area and adding supplementary form of treatment for MO is necessary. Nevertheless, the patient did make a faster return to sport after incorporating the new device, ESWT, but this study has some major limitations which should be further investigated in future research. The first limitation I would say would be because there was a lack of supporting studies, especially the fact that there are no studies with controlled trials and descriptive case reports. The patient population in these studies are also very limited and fall under the ages of 18 and 50 years old, which excludes the pediatrics and geriatrics population. The patient also gained a significant amount of range of motion over the past 2 months before he started the treatment, which could potentially hinder any definitive claims or definitive conclusions to be made. More research is also required to establish the timeline for the start of the treatment, the number of treatments that are usually necessary, and to confirm the safety modalities of this device. Here's my references. Any questions?
I thought that was a great presentation. I have one question. So what would you think that this treatment would be effective in combination with the other treatments that you mentioned towards the end, or do you think that this is something that should be implemented by itself, or would further research be needed for this?
Excellent question. Well, there definitely should be further research implemented in order for me to give you a definitive answer to that. But I would say as of right now, it has to be incorporated with stretching exercises, weight-bearing exercises, and it can't be a one and done sole device, and you can't just use it by itself in order to see full-on effect. So I would say you would have to implement it with other rehabilitation methods in order for you to see a full recovery.
I have, again, as David said, that was a great presentation. How, other than increasing the population, how do you think there would be a way to improve the study in the future?
Definitely. Well, first we can add control trials, non-control trials. We can have one of the groups go through go utilize the device. We can have them like David said, have them do non-exercise versus exercise while utilizing the device. And there's just so many variabilities that we could throw into this research and possibly test the efficacy of the device. And like I said, you could also set specific timelines for when the treatment starts, set a number of treatment that would make it more effective, and as well as confirm the safety measures of it. Like as of right now, there aren't any research that goes through the downside of this device. So there's many ways that you could further explore this device and so on.
Hey, I have a small question. Would you say that myositis significantly affects the lifespan, given the information that you have in the paper?
Just to clarify, what your question is, lifespan of the individual's health?
Yeah.
Yeah. So individuals who suffer from such myositis, they have trouble moving, right? Due to the level of pain, due to how much of a distress they're experiencing in that portion that's injured. So yeah, if an individual is experiencing pain, they're more likely to not be able to move, they more likely are immobile, and they won't be able to exercise as effectively. So if this matter, it usually goes away by rest, and it goes away through just through a long period of resting. But if you're an athlete, then and you need to get back to the field, you do need to recover quickly. Nevertheless, if you're a regular person and exercise is essential for you to be healthy and salubrious, so therefore, if you can't exercise properly and you're constantly consuming without getting proper movement, it would affect you on the short term. Chronically, not really, but for a short term, acutely, it probably would affect you.
And one more question. Were there any trends in specific patient populations that were more susceptible to myositis?
Most certainly, yeah. The patients who participated in contact sports such as football, rugby, and sports that really emphasize the collision aspect of their athleticism, those are the ones that were most susceptible to this form of injury.
Thank you.
Yeah, very good talk, Borna. The question I have is, how prevalent is this treatment in the literature or within use in current playing populations?
Probably
or is it a rarity?
Great question. Yeah, this would probably go through the rarity side of the spectrum. You usually see these in institutions that are Division I that can truly afford, because this is an expensive device, right? They could afford this type of equipment. So you don't see this at every clinic. You see this at high-tech, institutes that really focus on athletes and sports. So it is not often where you see this device getting implemented, which is why, as I said earlier, it's been 20 years where they utilize the Rice method, the stretching method, in order for them to get rid of the myositis. So yeah, it is not often seen in the field of rehabilitation and sports medicine.
Yeah, so is with these high-end tools, it's very hard to see them being implemented at the community or even at the higher level community level, where you're trying to get that player or athlete just past community play to like maybe a developmental or something team. Even some developmental programs are not well funded enough to allow them to have this kind of equipment. So it really kind of limits. It may be great and worked out well for this young player, a 20-year-old, but the problem is that it's not prevalently used in society. And so it's hard to kind of really see the outcomes of this beneficial for community sport.
Absolutely, spot on.
All right, thank you so much.
Of course, thank you guys for having me.
Thank you, Borna, for your presentation. Our next presenter is David H. Lee, with a bachelor's in psychology and biology from Stony Brook University, State University of New York.
Thank you for the introduction. Can you guys see my screen?
Yes, sir.
Okay, so I'm going to be discussing the article, Hematological Profile and Martial Status in Rugby Players During Whole Body Cryostimulation. Okay, so first I'm going to go over the background and some of the aims of the article. Whole body cryotherapy, or they abbreviate as WBC, so I'll be sticking to that for the rest of the presentation, is relatively novel form of cold-based therapy. So the way that whole body cryotherapy works is individuals will be put into a chamber and then will be exposed to extremely cold airs, maybe ranging around -150 degrees Celsius for about 3 or 4 minutes, or the duration can change a little bit. And it's being used because it's touted to have many benefits, some of which include anti-inflammatory effects. So the two aims of this article was to determine if altering the duration and frequency of treatment would affect the hematological profile or Martial status. So I'll go a little bit more in depth into what I mean by hematological profile and Martial status. So for hematological profile, that has to do with blood testing. So red blood cell count, white blood cell count, platelet count, and like more specifics like hemoglobin or hematocrit levels, like the width of red blood cells, specific details like that you will see in the later slides. And Martial status, which is a new term because it's kind of coined by the person who wrote this article, but it has to do with iron content, which is very closely related to blood testing. And the second aim is going to be to determine if there is a threat of whole body cryotherapy being used with blood doping. So to go a little bit more into that, there is a potential if WBC affects for example, hemoglobin count, that it could be used to mask blood doping or like performance enhancing drugs. So I'll go a little more into the methods. The sample size was 27 male professional rugby players from the Italian national rugby team. The study is a little dated. It was done in around 2012. So please keep that in mind. The exposure to treatment that they had was 2 daily sessions that were after their morning and afternoon practices for 7 consecutive days, and they kept everything else constant. Okay, so we're going to look at the results. For the hematological profile, there was no significant change in leukocytes or white blood cells, and there was significant decreases in red blood cells, hemoglobin content, and hematocrit. And there was also significant increase in the red cell distribution width. So if you look on the table on the right, you can see labeled in red that there is not a significant p-value when looking at the leukocyte count, and there is significant value in the areas below. And then moving on to Martial status, which is not shown on the right, but there was a significant but slight decrease in both transferrin and ferritin concentrations. So to explain that a little more, transferrin has to do with like iron metabolism. So transferrin is a blood plasma glycoprotein that's responsible for iron metabolism. And ferritin is a protein that stores iron in blood. Oops, okay. So moving on to the discussion. There was a similar downward trend that we saw in the previous slide for the red blood cells, hemoglobin, and hematocrit in other studies that were also done. So for example, there was a study mentioned by Bubkowska and colleagues where they had a different testing method where athletes were introduced to 10, 15, and 20 daily treatments by whole body cryotherapy, but there was a similar downward trend. So we can see similarities in the results when patients were exposed to cryotherapy. And as explained, there was a lack of leukocyte change, and that suggests that there is no effect of cryotherapy on the immune system. And then moving on, the lack of an increase in hemoglobin argues against the use of whole body cryotherapy to mask blood doping. So what this means is in blood doping, individuals could possibly mask changes in their blood chemistry by combining it with other methods that might increase hemoglobin count. But because whole body cryotherapy does not increase, it decreases hemoglobin count, it cannot be used to mask blood doping. And then Marshall status indirectly confirms the anti-inflammatory effect of whole body cryotherapy. So what this means is sports-induced inflammation causes iron deficiency, and inflammation increases ferritin and increases transferrin levels. But we saw previously that both transferrin and ferritin levels decreased. So these are signs that whole body cryotherapy does indeed have anti-inflammatory effects. And lastly, the limitation of the study was the lack of a control group. And because this was done on professional athletes during their training, it was difficult to have a control group that wouldn't receive this high-tech training and then have another control group that did receive this training because they want all their athletes to perform well. So because of that, this study and other studies in the past have had difficulty in finding a sample that could be a control group. And these are my references. Thank you.
Hey, David, great presentation, by the way. I just have a quick question. So as far as cryotherapy, I know that it is a very commonly used method for rehab amongst athletes. And I was wondering if you wouldn't recommend this for any athlete, whether like, are there any athletes that should refrain themselves from using this because of an injury, because of the conditions of their sport or anything of that sort?
I think, correct me if I'm mistaken, Dr. Lopez, but I think as for the article itself, it didn't specifically mention any individuals that shouldn't use cryotherapy. Actually, like when this article was written, the availability of cryotherapy was not as wide as it is today. So I guess in that sense, there's more relevance of the use of cryotherapy, but I'm not 100% sure if there are any cautionary signs for individuals in using cryotherapy. There are specific dangers if exposure to cryotherapy is too long. So as long as these very precautionary things are kept to a T, it should be relatively safe for individuals. But please chime in if you think otherwise.
Great, thank you so much.
Yeah, thank you for the question.
Hey David, I have one more question. What would you say is the biggest con or danger in blood doping, and which facet of it should you think there should be more research on?
So kind of to understand your question, like a con in blood doping, as in like how it works and why it provides like an advantage. Like, is that what you're talking about?
So like a negative side of negative effect of blood doping that should be researched more. What would you say is?
I think definitely to do more with this study and what this study talked about, there are potentially other treatment methods that might increase hemoglobin count and or change blood chemistry, and it could mask the unfair beneficial effects that individuals would get from blood doping. So if there were other areas of study, I would think to do like hematological profile analysis of different treatment methods and see if those treatment methods have like a similar increase in hemoglobin content that might signal that it's a danger in using those treatment methods along with blood doping as a masking method.
Thank you, David.
So thank you for the talk, David. That was very well done. The unique thing is, I think cryotherapy and its use has been goes back thousands of years, and probably some of the cultures in which we come from. I think Vlad and David, both of you coming from Russia or Korea, you guys know that cryotherapy is part of the culture. Full submersion and cold, whether you're at the spa in that capacity. So it's been done for thousands of years. How they're applying it now, I guess the only medical, cryotherapy is known not to affect heart or lung. So therefore, I don't think there's the only contraindication, and that would be anything that affects the blood vessels in comparison. So, or anyone who's like allergic to cold and they get hives and things like that. So I guess Borna would be the most senior. Borna, do you have an idea of a phenomenon that causes arterial spasm leading to possible ischemic necrosis? There's a particular it's called, phenomenon, and you need to know which one this one is. It impairs circulation, peripheral, has impaired circulation, peripheral vascular disease, very, very common. Open wounds and local infection. Raynaud's phenomenon that causes arterial spasm and leads to necrosis. So, maybe it would be a contraindication with anyone of this disease. So that may be the only reason not to apply this type of treatment of care. They even use cryoablation for arrhythmias in some types of care instead of heat ablation. So it's not uncommon to see this, but there's no contraindication for arrhythmias or lung issues. The only one would be probably the allergy to cold or hives, and therefore, or Raynaud's phenomenon. But otherwise, I think the importance of it is anti-inflammatory, and to bring it back around to rugby is that some of the current papers that we've been evaluating women's rugby players and their core temperatures increasing, and even with them using cold jackets, they have a whole, but again, right, we know that having a whole freezer with cold vests there for athletes is only seen at the very, very high level, and maybe even only in stadium play. Maybe not even seen with a traveling national team. But they've seen some benefit with rugby women's players using these cold vests due to the increased in core temperatures that they encounter. So it's relevant, and that's why the paper was suggested to be presented, to bring that back home to the rugby sevens women's players encountering high core temperatures, and therefore maybe we can evaluate, maybe this would be a benefit for them to be applied, and something may be suggested to the Northeast Olympic Development Academy to be used. Maybe a couple sessions of these prior to, and we could see if that would benefit or help that population in playing. On that note, thank you.
All right, thank you so much for your insight and for clearing up the previous question from Borna. I will stop sharing screen now.